Good afternoon. Sam Grisham, the investigator for Marion County Board of DD. What I want to do today is I'm going to come on here and go over some of the updates for providers, and I'm going to share my desktop at this time. If I can get this to work here. And hopefully you're all able to see that. Let me see if I can expand that. I think it's going to allow me to. So anyway, 2025 MUI updates. I'll go through these slides real quick. An administrative investigation, there's two types of investigations actually, category A and category B, which are your abuses, deaths, neglect, misappropriation, your significant others, failure reports, missing individual rights codes. The two categories are category A and category B. The category A and category B are all completed or conducted by the investigative agent, which is me. Then we get into the administrative review category C's, which is your appendix C, D, and E forms. That's the forms we keep hearing about and keep talking about, and I'm going to show you those forms here in a minute. Law enforcement, unanticipated hospitalization, and unapproved behavior supports are the category C's. The one primary one that you'll be most interested in would be category for unanticipated hospitalization. Whenever the provider gets a hospitalization, for an example, after the person has been there for 48 hours, you want to make sure you know what that diagnosis is that they're admitting them for. If that diagnosis falls within the categories of a hospitalization, which is bowel impairment, seizures, sepsis, aspiration pneumonia, mismed, med-error, and so on, and we'll go over that here in a minute as well. You want to make sure you put that in that report, that that's what they were admitted for. So when you submit your incident report, you'll submit those forms at the same time, which also means you're still going to be required to call and do the notification to the on-call. The expectation of that is still to follow that process. Call the on-call. Once you call the on-call, say, Sam went to the hospital. You will follow up in 48 hours if that person is admitted and they're still there after 48 hours. You will let us know what they're admitted for. And if it's one of those categories, you'll have to submit your incident report along with the appropriate appendix C, D, or E form. C is actually your law enforcement, D would be your hospitalizations, and E is unapproved behavior supports. One of the rationales, or some of the rationales for the changes, is CMS focuses on more serious and repeated hospitalizations. So that's kind of what we did with the adjustments in the hospitalization rules. We have a lot of people going in the hospital getting admitted for a UTI or getting admitted for treatment and observations. Well, CMS is not really too concerned with that as much as they would be for someone who had aspiration pneumonia or someone who had sepsis or someone who had a med error that required them to be hospitalized. 37% of all my MUIs are for hospitalizations. This is not looking at a way to reduce the workload of IAs, but it's to make the investigations more meaningful. Readmittance in a hospital within 30 days. What they're talking about there is if a person, say, gets admitted and they're in there for 48 hours, they're admitted for a UTI. They get out. And within the next 30 days, they go back for the same symptoms, same diagnosis, UTI, to be treated. Then I would have to file for that UTI, even though it's not one of those 6 categories. We want to focus on the conditions that result in most hospitalizations and deaths in people with DD. The other thing is hospitalizations that are not deemed as MUIs are still investigated, but they're looked at by the providers to see what we can do, but they're looked at as an unusual incident. You're still going to follow up, make sure the individual gets to the follow-up appointments. You're still going to make sure that the individual gets the medication changes, MAR updated, all those things that we did before, you're still going to be doing. Most of the providers do that currently. They continue to do that. Category B's, or C's, Appendix C. This is for law enforcement. Very seldom does an agency provider have someone get arrested or get charged. It does happen, but very rarely. Most of the law enforcement allegations are for individuals who live within the community who receive drop-in services, or they live in a community on their own and get very limited services. Doesn't have a provider that comes and provides services. They're very high functioning within the community. They get arrested or charged with DUI or domestic violence or simple battery. Those are the ones that would do those. Typically, those that are not being receiving services through a provider, a paid provider at the time of the incident, the SSA or myself, we will find out about that through some one way or another. The individual calls and tells the SSA, or sometimes the individual calls and tells me. Or we'll be reading in Marion Crime Chronicles. Everybody's famous. So we'll look at Marion Crime Chronicles and we'll see that someone was arrested or charged with a crime. I'll verify that they were arrested or charged. And once that verification is made, I'll file the MUI. Again, this is just the Appendix C form, section prevention plan. Should a provider be with someone when they get arrested or charged with a crime? If you're in a group home, say it's a peer-to-peer, and it was physical, and somebody wanted to press charges against another peer for striking them or hitting them in the face, giving them a bloody nose, and they do charge them. Say they do charge that person with that crime, then you would complete this form, submit your incident report, and this form at the same time. When an individual is hospitalized, the provider is responsible for following up the hospital so a diagnosis is determined as soon as possible after the 48 hours. Your incident report and the form D, Appendix D, is submitted at the same time. Your date of notification, the date you became aware of the incident, is the day, the 48 hours. On that 49th hour, if you know that a person was admitted for sepsis, that's your date of notification. Even though they've been in the hospital for 2 days, you did not become aware that it was possible or could lead to an MUI until that 49th hour when you were notified. That's why it's crucial that providers reach out to someone at the hospital to contact them to find out what that person was admitted for and what they're being treated for. Again, unanticipated hospitalization means a hospital admission lasting 48 hours or longer that is not associated with the planned evaluations, scheduled procedures, or routine diagnostic tests that are part of ongoing medical care, including the diagnosis of conditions, and is due to one or more of the following diagnoses: aspiration pneumonia, bowel obstruction, dehydration, medication error, seizures, and sepsis. A hospital readmission lasting 48 hours or longer that is not associated with planned evaluations, scheduled procedures, or routine diagnostic tests that are part of ongoing care, including the diagnosis of conditions, and is due to any diagnosis that is the same diagnosis as a prior hospital admission lasting 48 hours or longer within the past 30 calendar days. Your 30 calendar days starts from the day they leave the hospital. So if they leave on January 1st, then on February, but actually March the 2nd would be your 30 days. January is not a good month to pick, I guess. Appendix D is your unanticipated hospitalization. This is the form you will become most used to doing. Again, just fill out the header, all the information except for down here where it gets to, it tells you investigator, to be completed by the investigative agent in collaboration with the individual's team. Once you get this all filled out, give me as much information as you can. I'm going to rely heavily on this. Investigations, the way we do them now currently, where I'm constantly reaching out, finding out 72 hours, all that information's in here. You need to have that information in here so I don't have to go back and get it. Once I get it, I'll verify that things were done. I'll give details of the hospitalization, the admission, the discharge, of what they were in there for, and then the prevention plan. What is the team doing to reduce the likelihood of an incident reoccurring? It's been proven that majority of hospitalizations are preventable. Again, this is the last section of the form that I will complete. Again, the providers will submit or should submit the incident report, Appendix D, which is this form, and the discharge paperwork. I need the discharge paperwork to the county by 3 p.m. on the first working day following the day the provider becomes aware of an unanticipated hospitalization. Say someone gets admitted, they've been there for 48 hours and they were admitted for a UTI for treatment, and that's what they're treating for. You knew that the day they admitted them, but you waited for that 48 hours to make sure it met the criteria, because there's a lot of criteria that needs to be met. 48 hours is the cutoff. So on that 49th hour, they still haven't gotten out of the hospital. So submit your incident report and submit the Appendix D paperwork to me by the reporting timelines, 3 p.m. the next day. If they get discharged before you send me that stuff, send me the discharge summary with that. If they don't, send the discharge summary as soon as they get discharged. Most cases, you will give me the incident report and the Appendix D form, and it'll be another 3 or 4 days, sometimes a week or two, before you get the discharge summary. Send me that as soon as you get it. Appendix E, unapproved behavior supports. Again, just fill in all the blanks, leave nothing. The only thing you won't be able to do is put an MUI number, because we can't determine if it's an MUI yet. So the MUI number is what I'll put in. You fill out everything all the way down here to where it talks about the investigator of services. The investigator completes part 2 right here. So all this prior to that, this and this has to be completed. What type of hold was used? What was a physical restraint? Was it a chemical restraint? Was it a medical restraint? What was the type of hold or unapproved behavior support used? Get all that stuff filled out, get it to me. I will get back with the team and we will do work. You guys will have a prevention plan moving forward. What can we do to reduce the likelihood? Again, a provider should submit the incident report and Appendix E by 3 p.m. the first working day following the day the provider becomes aware of unapproved behavior support. Verbal abuse was changed to emotional abuse, which means the use of actions, words, gestures, or other communicative means to purposefully threaten, coerce, intimidate, harass, or humiliate an individual, or a pattern of behavior creates a hostile environment. And I'll give you some examples here in a minute. Person alleges their staff threatened to punch them if they did not do the dishes. Staff take an unflattering photo or video of a person and post it on social media, i.e. Facebook, Twitter, or Instagram. I actually had an independent provider who's the mother of an individual who took a photo of her daughter with a sign on her that says, "I'm a thief and I burn my brother's stuff." And then she sent it to a day program provider, and it was done as an act to intimidate, coerce, or threaten. She did it to coerce her daughter to quit doing those things and saying that she was evil and all this stuff, and God doesn't like evil people. So that in and of itself, I filed a verbal abuse at the time is what it was. I filed verbal abuse because it met the criteria. Now it'd be called emotional abuse. Home manager sprays a person in the face with water to coerce them into getting out of the bed or doing their chores. You can't do those kinds of things. If it's anything that can cause someone emotional abuse, an individual gets upset. Maybe you thought it was no big deal. You've done it for months. You sprayed them. But guess what? They get off the bus at the day program. They walk straight into the day program. They start crying and they start saying, "My staff sprayed me in my face every morning when I get up and I almost drown and it goes up my nose and they scare me and I don't want to go back home." Then it becomes a bigger issue than what we meant it for. Intentions may be great, but they're not always the best choices. Another example, a staff member works with a person who is known to be very sensitive to loud noises. Despite being trained on this and repeatedly reminded by supervisors, staff appears to intentionally slam doors, clap loudly near the person, causing them to flinch or cover their ears in distress. This behavior occurs consistently over time. Other staff report seeing the person become visibly anxious, withdrawn, and upset when the staff member is on shift. Staff member discusses concerns by saying they're just joking around or that the person is too sensitive. That right there falls under that category right here. Pattern of behavior that creates a hostile environment. That's emotional abuse, and it will be filed as such. Failure to report means the developmental disabilities employee does not immediately report an allegation or suspected or actual occurrence of an individual suffering or facing a substantial risk or suffering any wound, injury, disability, or condition of such a nature as to reasonably indicate emotional abuse, exploitation, misappropriation, neglect, physical or sexual abuse to the agency, provider, county board, or department. You have to report these things. We have to be able to ensure their health and safety. If we don't know about it, we can't do something about it and put preventions in place. Death categories were renamed to align with CMS language. The investigation protocols are still the same. They remain unchanged. Unexplained or unanticipated death means the death of an individual resulted from an accident or was otherwise unexpected. Death other than explained or unanticipated means the death of an individual by natural cause. Medical emergency definition was changed to read this. It was basically changed to clarify that medical emergencies are filed only when completed by a DD employee. Removal of the EpiPen from definition was taken out. They did add the use of overdose reversal medication administration. And so now the description of medical emergency means an incident where emergency medical intervention by a DD employee is required to save the life of an individual. From the example they gave there was choking relief techniques, CPR, or AEDs, the automatic external defibrillator, and or administration of overdose reversal medications such as Narcan. Missing individual was changed to include the more serious case when law enforcement was notified. And I put and bold there because I need both these criteria, and the person is at imminent risk. Missing individual means law enforcement has been contacted because an individual's whereabouts are unknown and the individual is believed to be at or pose an imminent risk of harm to self or others. Individual gets upset in the home, says, I just wish I was dead, and then takes off. We don't know where he's at. We notify law enforcement. So the first part of that's met. Is there any risk of harm? Well, he said he wished he was dead. How do we know that they're not going to go out somewhere and cause serious harm to themselves? Step in front of a car. They may have some medications they can overdose on, or they grab something to cut their wrist. So we have to file that. Verbal act was removed from the peer-to-peer definition. The new definition for peer-to-peer includes these four types: peer-to-peer exploitation, peer-to-peer theft, peer-to-peer physical act, which is a physical altercation, or peer-to-peer sexual act. Significant injury means an injury to an individual of known or unknown cause, and they added this red in here, that results in a dental injury that requires treatment by a dentist, a concussion, broken bone, dislocation, or second or third degree burns, or requires immobilization, casting, or 5 or more sutures. Again, previously, this was in UI, results in dental injury, requires dental treatment. Someone gets hit in the mouth in the day program, peer-to-peer physical, for example, and it requires them to go to the dentist because they chipped their tooth, or they knocked their tooth off, or they knocked their tooth out. That then becomes a peer-to-peer and a significant injury incident. Individuals in the day program or at home even, and they fall. And the fall, they go down, hit their face on the floor, and it knocks out their 2 front teeth. That requires dental injury, that requires dental treatment by a dentist. That then would be filed as significant injury. Immediately upon identification or notification of a major unusual incident, a provider will take all reasonable measures to ensure health and welfare of at-risk individuals. Reasonable measures include, but are not limited to, securing the immediate and ongoing medical attention and or removal of a DD employee from direct contact with an individual when the DD employee is alleged to have been involved in the physical or sexual abuse. And the providers will document reasonable measures taken and by whom in the incident report. I get a lot of incident reports from agencies that the notifications are pretty much all internal. There's no external notifications. They don't indicate that they notified the guardian. They don't indicate that they notified someone designated by the individual or the individual if they're their own guardian. They don't do those notifications. You have to document those notifications. Removal of DD employees. Agency provider will inform the DD employee of an alleged major unusual incident category and provide the DD employee with the name of a person employed by the agency provider to whom the developmental disabilities employee may direct questions. I get tons of questions for people that are on administrative leave or have been removed from the schedules. They call me over and over and over. I will not disclose to them any information other than you need to contact your supervisor or you need to contact your provider. I tell them I'm not in the hiring and firing business and I don't disclose anything. If they say, well, was it substantiated? I'll tell them you will receive a letter at the end of my investigation that says it was either substantiated, unsubstantiated due to lack of evidence, or unsubstantiated, unfounded. Those are the three categories that I will tell you. It will tell you again, substantiated, which means it's more than likely to have occurred, and I can identify you as the PPI, or unsubstantiated due to lack of evidence, or unsubstantiated, unfounded. Very rarely do I find unsubstantiated, unfounded. County board, as applicable, will keep the agency provider apprised of the status of administrative investigation so the agency provider can resume normal operations as soon as possible, consistent with health and welfare of individuals. Agency provider will notify the county board or department as applicable, whoever's doing the investigation, when the DD employee returns to work. If I have somebody off work, you have somebody on administrative leave, trust me, I know that puts a hardship on you. I will do everything in my power to get some kind of summary rundown within 72 hours of starting my investigation. I will let you know that. If I cannot do that, I will keep you updated and informed. County board will inform the independent provider of the alleged MUI category and provide the independent provider with the name of a person employed by the county board. So for independent providers, they will contact the county board. I'm going to say for us at the county board here, it's more than likely going to be the SSA director, whom I have meetings with every week and I talk to every day about MUIs. They too will not disclose information other than about how much longer it could take or specifics such as that or what their next steps are. But as far as the ongoing investigation, they too will not disclose any sensitive information to someone who's a PPI. County board will keep the independent provider apprised of the status of the administrative investigation so the provider can resume normal operations as soon as possible. In conjunction with the department, the county board has the authority to remove an independent provider from direct contact with any individual when the independent provider is alleged to have been involved in physical or sexual abuse until such time as the county board is reasonably determined that removal is no longer necessary. When the county board removes an independent provider from direct care or direct contact with an individual, we will make sure that we keep you informed what's going on, who you need to reach out to, and things of that nature. Staff of an agency provider will inform the director of operations or administrator of the agency provider within one working day following the day the staff became aware of a potential or determined MUI that involves misappropriation, neglect, physical abuse, or sexual abuse. Most all, if not all, have a policy about reporting for notifications. At the county board, if you use Britco and you submit an incident report to Britco, every administrator and myself, those people that need to know the SSA managers, the administrators for the county board have all been notified. Typically, most agencies that use Britco, your administrators have notifications in that process, or you have a supervisor who's calling and notifying those people. Sorry about that. I had to get some drink. My throat's getting dry. General investigation requirements. All MUI category A and B require administrative investigation. Administrative investigations will be conducted and reviewed by the investigative agents. The IA will make sure all MUIs are properly coded, resolved. Any outstanding questions or concerns with the individual's provider and or individual's team. Identify the causing contributing factors to the incident, and I address the prevention plan. The team is responsible for getting me the prevention plan. Typically what happens is people wait till the last day that they get a chance and I send them and say, hey, here's causing contributing factors. Don't wait for me. You guys know what's going on. You know what caused someone to fall. If it's a fall and they break their finger, you know what caused that. You know the causes a lot faster than I do, than I can determine them because you're present. So start working on your prevention plans whenever you send that incident report in. Disputing the findings of a written summary. Individual's guardian other person whom the individual is identified, or provider, except when the primary person involved is an independent provider, owner, director of operations, or administrator of an agency, may dispute the findings of a written summary of an administrative investigation described in paragraph K1 of this rule by submitting a letter. This is your dispute letter. And supporting documentation to the county board superintendent or to the director of the department if the director of the department conducted an investigation, and it has to be done within 15 days. The only thing they've changed in this section is if the PPI is a provider, you can't appeal it. You have no appeal process. If it goes to the abuser registry, that is your appeal process. You have a chance to plead your case in front of a judge advocate. Director of operations, the owners, independent providers, or administrative agency provider. If you're in an administrative role and you're a PPI, there is technically no appeal other than the abuser registry. Independent providers are no longer required to do annual reviews. Agency providers are still required to do this, and it's to be submitted to the county board no later than February 28th of each year. Independent providers should continue to work with teams to ensure that people's plans address the risk associated with trends of unusual incidents and MUIs. If you're an independent provider and you have an individual who has a lot of hospitalizations or has a lot of MUIs, by all means, work with that SSA and the team. Get together and y'all talk about this. What can we do moving forward? How can we address these trends and patterns? Is there something that the doctors are not doing we need to make sure that they're doing? UIs. All providers have to maintain the UI logs and review them monthly for trends. However, they only need to submit to the county board upon request. Currently, we submit UI logs quarterly. I would send out an email saying, send me your UI logs for review. You would send them to me. I would review them. The problem with that is if I found something that was not addressed in that, so you didn't have a prevention plan, or it was an MUI in the UI log that shouldn't be there. And I tell providers that, they say, okay, and then they never make a change. Next month, I get the same thing, or next quarter, I got the same thing. So that was the biggest concerns we have with that, is we're spending a lot of time on these UI logs. Things are not being done. However, accreditation, for your accreditation reviews, they will be looking more seriously at these logs. And if you're not doing them appropriately and they find a lot of mistakes, you may receive a citation if you're not following the requirements. When no unusual incidents occurred during a calendar month, I get this question all the time. What do? You have to make a notation to that effect on the log of unusual incidents. So if you had no UIs, and a lot of independent providers don't have a lot of UIs. So if you have no UIs, that first line, put the month and the year, and right underneath it, the next line, write no UIs or no unusual incidents. Members of an individual team will ensure risk associated with unusual incidents are addressed in the individual service plan of each individual affected. We got to make sure this is happening. If there's some risk associated with UIs, trends and patterns, we need to make sure it's in the plan. When an unusual incident involves a hospital stay, the provider and the team will review what preceded the hospital stay and consider what could have been done differently to prevent that hospital stay, other than refusal. If they have a UTI, then we maybe need to look at how we can get them to take more fluid to keep our kidneys flushed, things of that nature. Excuse me. All providers have to maintain an unusual incident report log monthly and review for trends. They only need to submit it to the county board if requested, or to the department if requested. County boards do not have to review the UI logs on a quarterly basis. However, we can request them at any time. UI logs will still be reviewed during compliance reviews and upon request. The department will no longer review the county board's operating programs, unusual incident report logs on a quarterly basis. I still review it. I still log it. I still look at, make sure there's no trends and patterns. If there is, we address them. Some more minor changes under UI. One of the things about UI logs or unusual incidents is they moved that to an appendix F to the rule. They took it out of the policy in and of itself and moved it to F. It means event or occurrence involving an individual is not consistent with routine operations, policies, and procedures, or the ISP, but is not an MUI. They include, but not limited to, the events and occurrences described in Appendix F. So look at Appendix F of the rule when the rule comes out. Incident report should include the date and time of the incident. Description of the incident answers the following questions: who, what, when, and where. Service and support administrators now defined in the rule. They actually highlighted the service and support administration in the rule. We eliminate an agency provider submit internal review of a major unusual incident to the county board. Sometimes there's agencies that will conduct their own investigations and they'll submit that report to the county board. Just like the next line said, the ICFs were pretty good at that. ICFs should still submit that report to me. I will submit my report to them. I'm not required to, but a lot of times it's a lot easier if we're making sure we're on the same page. So those agency providers who submitted internal review and their findings to the county board for the county board to use instead of the county board doing it are no longer required to do that. I appreciate your time. I know this was fast. If there's any questions, feel free to give me a call at 740-375-6190. That's my direct line to my office. For the agency providers, you do have my cell phone. I won't put it out there in public for everyone to have because I don't need anonymous calls. The other thing is, if you have any questions, you can't reach me, you can always contact our on-call at 740-225-9310. They will always know how to get in contact with me. They may not share my phone number with you, but they can get in contact with me and tell me to give you a call. Again, I appreciate everything that everybody does. And I mean that. I don't just say it. I really do mean that. And we hope you have a great day.